good morning in Brazil, and happy Easter to all of you. Welcome to this CME program of Kerala Society of Ophthalmic Surgeons. See, we at Kerala Society of Ophthalmic Surgeons have been doing a scientific committee CME series programs very regularly. If you take this year, we have already done about 13 programs, and so this is this would be definitely one of the best programs that I've ever done. And I'm Dr. Neto. I'm chairman of Scientific Committee of Kerala Society of Ophthalmic Surgeons. I'll just give you an idea as to how I thought of this program. I had invited Dr. Neto for another program. That was a 4-hour program. I requested him for talks in that. And so that day when I talked to him, he said he might not be able to join because he'll be on road and he will be traveling about 550 kilometers or so to operate 100 plus surgeries on the next day. See, that was phenomenal. And I see all these things, some things bring you really crashing to ground. I was under the impression that probably being from India and doing about regularly doing 50 cases a day and 800 surgeries in a month, I might be one of the highest volume surgeons in the world. And just to hear that Dr. Neto is doing 100, 150 regularly, daily, sometimes more than 200, that was a revelation for me. And so I was so impressed with what I learned about Dr. Neto. I really wanted to do one full session with him, exclusively with him, because we all want to know, because when it becomes high volume, there are a lot of issues here. I was just talking to Dr. Neto just before this live started. He says he keeps on saying high quality. So how we maintain the high quality while doing the high volumes is something that we should all learn. And it's the doing surgeries in a high volume, learning his technique, that is one. Maintaining the high quality, maintaining high quality results as you do the high volumes, that is something I'm sure that we are all going to learn from this program. And I have with me 3 of the real prolific phacosurgeons in India, Dr. Sunil Thangaraj, Dr. Minu Mathan, and Dr. Matthew Kurian. So Dr. Sunil Thangaraj is of the 3 of us is closer to Dr. Neto, and I would request Dr. Sunil Thangaraj to give our viewers an idea about the life and practice of Dr. Neto. Dr. Sunil, please.
Thank you, Srini. Yeah, what can I say? If I start talking about Neto, then Neto cannot talk on this program. So I think I'll just say that I've known him. Actually, we met on Dr. Pradeep Mohanta's OSW Cataract Forum, great forum. I would invite everybody to join that. That's how I met all these great people. That's how we met and we clicked. And what I have come to know of him, he's a very humble, extremely intelligent, meticulous, hardworking, very innovative, very approachable, great teacher, and I can go on with the adjectives. And he had a huge private practice which he gave up, and he is doing what he's been contracted by the government. He goes all over Brazil and also all over the world doing surgeries. He keeps on getting awards. I don't know how many awards he's got. And he teaches, and his techniques. And if you look at his videos, please go to his YouTube channel, the Cataract channel, and you will see fantastic videos. These are very high quality. Believe me, it will take a lot for anyone to reach that standard of surgery. And and he has changed me. After 20 years of being a direct chopper, I'm now using his techniques, trying, and I find it extremely good. And I don't want to go on. He has got a beautiful wife, Agda, who's now, I think she's helping you in theater, right? Right, Neto? She's also qualified and she's assisting you in theater, right?
Yes, she was my chief main nurse for many years, for about 8 years. And around 5 years ago, I convinced her to study dentistry, and she graduated last year. She's now starting her private practice in dentistry, but she still, let's say, travels with me. She's now, again, my chief main nurse, and she helps me with everything, teaches the team and everything. So she's let's say, she's an invaluable companion to me to be able to achieve that. And I'm lucky that, as I stay so much time outside my home, she can come to me and be at least half of the time with me, because if not, it would be impossible to maintain this marriage, because I'm away like 20 to 25 days each month out of sometimes I stay out for 50 days. And so, and she loves what we do. She loves to help, and she's an amazing nurse. Let's see, it's let's say it's because of what she does that we can maintain the high standard, high quality standard for everything, all the protocols, everything. She's the one that takes care of it.
Fantastic. I think, Srini, you heard that. I don't know if Neto proposed to her, but anyway, we'll find that out later. Now, I think you can carry on with the program.
Dr. Neto, we'll start your presentation.
Okay. Well, I must thank you for the introduction. Thank you, dear Sunil, for being so kind. Your kind words. I could say
honest and truthful.
The same reciprocally, because I have learned so much from him, and he's been my SICS mentor. Let's say about that. Let's say. Like a remote mentor, and I learned so much. And I'm going to India for the CCC 2023 in November, and I hope to meet you all there. So, so should I start my presentation?
Please start. Please start.
Okay. Is it running?
Yeah, visible.
Okay. So I will talk initially about 3 techniques I developed to improve my high volume phaco surgery in Brazil. What are my thoughts on cataract surgery? I think it is something extremely personal, meaning that each surgeon has an almost unique way of operating, from handling the instruments to approaching a particular case. That is why it might be reproducible between different surgeons, or definitely not in some cases. It can be said that there are as many phaco techniques as there are surgeons, meaning that each surgeon has his or her personal one, which can be an adaptation from existing techniques or a completely new one. It becomes clear then that there is no best phaco technique. That's something very personal for each surgeon. By refining techniques and achieving proficiency in surgery, the surgeon can achieve what can be defined as art, in the sense that it is the expression or application of human creative skill and imagination, still not only in a visual form as art is commonly defined, but in a functional way as well. It is very important to be open to experimenting with different techniques with perseverance. If some technique is being successfully used by some surgeons, it is worth considering incorporating it into your surgical armamentarium. one should take the opportunity to learn from other surgeons' experience and also mistakes. That is why events like this one are a very important way to share experience and everyone can learn. Phacoemulsification cataract surgery has constantly presented changes that have improved it over the years. The low rate of complications made it a very safe surgery. Advances in equipment and technique have provided rapid surgery. It became a very convenient surgery for the patient, with no discomfort or important limitations in the postoperative period. The technical scientific refinement provided great predictability, both in terms of results and especially in terms of refraction. All these characteristics have led to important change in the way patients see cataract surgery today, making it more desirable and at the same time greatly increasing their expectation for the results. Many changes also took place from the surgeon's perspective. Cataract surgery is an essential part of the professional practice of most ophthalmologists, but it is a surgery that is notoriously challenging to obtain technical excellence. The ophthalmologist needs to provide the patient with a quick recovery and an excellent refractive result. Efficiency in terms of surgical time, using little material and reducing cost are essential, especially for those performing large volume surgery in which economies of scale count a lot. With all these considerations in mind, I want to bring something that can be used immediately and in the broadest possible way by the majority here, no matter the level of surgical skill or volume of surgeries performed. This practice have helped me optimize time, achieve better outcomes, reduce complications, and simplify the surgery. The two first techniques I developed myself. There is no description of them in this way in the literature. And the third one, although already described a long time ago, it is very underused. I'll start by presenting here a surgical technique I developed and I am most known for, and which makes a big difference in my practice, the nucleus spin, and afterward its evolved form, the nucleus sweep and spin. What is the nucleus spin? It is a fast and repetitive nucleus rotation. That's why I named it the spin, in both clockwise and counterclockwise directions. The spin is performed after hydrodissection, but it is not that small and simple nucleus rotation intended only to free the nucleus. The purpose of the spin is cortex release, achieved because the nucleus rotations drag the epinucleus and cortex along, detaching them from the capsular bag. But why cortex release? Why is it important? Cortex management is an essential surgical step. It is time-consuming, including the need to switch probes. Cortex removal can present difficulties. Subincisional, equatorial, and posterior capsule adherent cortex can be challenging to address. Intraoperative meiosis can hamper cortex visualization, making its removal troublesome. Most importantly, it has been shown that most posterior capsule rents happen during cortex management. It is clear then that it would be extremely beneficial to facilitate or eliminate this surgical step. Two maneuvers can help it. One is the well-known and universally used cortical cleaving hydrodissection, but it often is not enough to achieve that. In conjunction with the nucleus super or over rotation, the spin, complete cortex release is achieved in most cases. The spin technique is simple. It should be performed right after hydrodissection, with or without hydrodelineation. under irrigation by the phaco probe or under OVD, using an instrument like the chopper itself or a Sinskey hook. The spin maneuver can be performed in phaco and manual small incision cataract surgery. Multiple clockwise and counterclockwise rotations are performed. Usually 5 rotations in each direction are sufficient. Around 10 ensures complete cortex release in almost all cases. During the maneuver, cortical and epinucleus matter is expelled from the bag and can be aspirated for visualization purposes. So, what are the advantages of this technique? The spin is effortless to learn and perform. No special instrument is needed and is easily incorporated into the surgical routine. It is a fast maneuver, which saves much surgical time when complete cortex release is achieved. It is very zonular friendly. The forces are applied tangentially to the entire zonular apparatus simultaneously. Cortex release and expulsion provide free space in the capsular bag, useful during nucleus management. It diminishes or completely eliminates the cortex management step, saving time and providing safety. It would be logical to speculate that the maneuver friction removes lens equatorial epithelial cells, diminishing the posterior capsular opacification rate. Let's watch the technique. Right after hydrodissection, I free the nucleus with small back and forth movements using the long chopper. Then, multiple clockwise and counterclockwise rotations are performed, 10 times in each direction here, as this helps by removing lens equatorial epithelial cells. Any phaco technique can be employed for nucleus management afterward. Here, the carousel technique was used. No cortex or epinucleus remains. About 2 years ago, I started to evolve the spin to achieve even better cortical release, incorporating a technique I developed for posterior polar cataracts, the mechanical cortical cleaving, which is the mechanical detachment of the cortex from the capsular bag, performed by sweeping a long blunt chopper along the lens equator. In this way, the sweep and spin technique was created. I first perform a mechanical cortical cleaving on 180 degrees of the lens with the chopper, and then continue in the same movement by doing the regular nucleus spin rotations. So what are the advantages of the sweep and spin over the regular nucleus spin? The sweep maneuver promptly and effectively detaches all cortex from the bag in at least 180 degrees. The already separated cortex is dragged along, helping to detach the remaining cortex. As cortex detachment is more effective, fewer nucleus rotations are needed. It is even faster than the regular spin. And now the sweep and spin. Gentle hydrodissection is performed. Then, before nucleus rotations, the long blunt chopper traverses the lens equator opposite its entry side, separating the cortex from the capsule and dragging it along. Nucleus rotations begin, and now all cortex is detached and carried with the nucleus. Only a few nucleus rotations are necessary with this technique variation. Nucleus management is routinely performed and no cortex is left upon completion. Let's watch another case. Please pay attention to how the cortex is detached and dragged along. This greenish image is a custom digital filter I developed for better contrast and definition of the capsule and cortex on the Ingenuity system. The technique is very effective in detaching the cortex. Hydrodissection with only a thin fluid sheet helps to achieve a better result. Avoid overdoing hydro. Nucleus management is greatly facilitated as the nucleus is entirely free and the released cortex epinucleus provides space. As I mentioned, any phaco technique that the surgeon is familiar with can be used after the spin. In conclusion, both techniques were developed to enhance cortical release, conferring safety and abbreviated surgical time. The spin is straightforward to learn and execute. I recommend surgeons to master this technique before moving to the sweep and spin, which is more effective but more challenging to master. The sweep and spin requires a long chopper of 2 to 2.5 millimeters in length for maximum effectiveness. The simple spin does not. One can slowly build the skills required to perform the spin and the sweep and spin and increase surgery efficiency and safety. If at first an idea is not absurd, then there is no hope for it. I'm going now to present the wedge, a phaco technique I developed and use in the vast majority of my cases. Please, I would like to ask if the presentation is going okay, if the video is playing accordingly.
Everything is absolutely
yes,
fine, Dr. Neto.
Okay, yes, because I have no feedback on my screen. Thank you. So, the wedge chopping is a mechanical fracturing technique, meaning that no vacuum or ultrasound is employed to divide the nucleus. The nucleus division is achieved by compressing the nucleus piece between the chopper and the phaco tip. Mechanical fracturing is a well-known phaco technique, and many surgeons use it. So why the name wedge? That refers to a modification I made to the technique. By positioning the tip sideways, its bevel acts like a wedge to initiate and propagate the cracking, cleaving the nucleus fragment while the chopper holds it. Let me talk about some technique details. It is a horizontal chopping technique. A long bend chopper with a blunt tip is recommended, usually with a 2 millimeter or bigger bent portion and a ballpoint for capsule safety. The chopper acts in bracing the nucleus equator. Now the important detail. The phaco tip goes sideways to present a bevel. A wedge, 45-degree tips are better suited for this technique. Using irrigation only, the chopper compresses the nucleus material against the phaco tip. The tip's wedge initiates the fracture, which is propagated along the natural cleavage lines of the nucleus. After complete nucleus division, the pieces are routinely emulsified. I'll first show the important detail of the technique, how the fracture is performed. Note that the aspiration and vacuum settings remain at 0 during wedge chopping. No ultrasound or fluidics are used to achieve the fracture. The tip goes sideways and the chopper hugs the nucleus, being brought horizontally towards the tip of the bevel as the fracture begins and completes in a clean line. This is a key difference between wedge and traditional mechanical fracture techniques using the front of the phaco tip. The sideways bevel has the shape of a wedge, and it is at the bisector of the bevel angle that the compression vector propagates, initiating the fracture. Compressive forces are concentrated in a small area, facilitating and making the action more effective. Here, then, is the complete technique. Notice the sideways position of the tip, which appears as a wedge. A long, blunt-end chopper is ideal. The one I use is 2.5 millimeters. Rotating the nucleus, I go completely dividing it into 8 pieces, although the 4-quadrant division is the most common method. The fracture propagation in the fragments can be seen following the natural cleavage lines of the nucleus. By using the Phaco's tip bevel sideways, acting as a wedge, the nucleus is divided using only mechanical forces. No ultrasound or fluidics are employed. Only then do I proceed to pieces emulsification, sequentially, one by one according to its location. Merits of this highly modular approach becomes clear, as control, safety, and ultrasound usage efficiency are outstanding. What are the advantages of the technique? The wedge chopping is very easy to learn and master, with no need to change the surgeon's parameters. It can be performed with basic or lesser machines and also associated with other techniques and during pieces emulsification. Nucleus hardness from 1 up to 3 can be approached by the technique, which is the majority of cases for most surgeons. The ultrasound power applied in the case is significantly less with the technique, which is unimportant in general sense, but especially in cases with compromised corneal endothelium, for example. By not using vacuum and ultrasound, safety is one of the hallmarks of the technique. Efficacy is maximized because the compression forces are applied in a very small area by the tip. With easy cracking, the phaco tip stays in the safe zone at all times. The chopper does most of the manipulation. As it does not depend on vacuum, it is very fast. Let's see more examples. I like to remove the anterior cortex for better visualization. Occasionally, aspiration is used only to unclog the tip. In this case, I split the nucleus into 6 pieces. The higher the hardness of the nucleus, the more splits I do. I like to divide the nucleus thoroughly first. Ultrasound is only used after the divisions when emulsifying the parts, significantly reducing the expended ultrasound energy. After ensuring the pieces are completely separated, I proceed to emulsification, which is facilitated because the pieces are already loose and free to be approached. In most cases, the division into 4 fragments is sufficient. Nucleus pieces are easily split with this technique and are not crushed as it is commonly seen in the traditional mechanical fracture technique. When the spin is performed in advance, almost no cortex remains. One can employ the wedge with a sideways motion against the tip, as in transverse chopping. The nucleus division is rapid, especially in softer nuclei. I strongly recommend that you all learn and use the wedge chopping mechanical fracture technique to enhance overall efficiency and safety. It is a valuable technique that can be used in most of your surgeries alone or associated with other techniques. Nothing is so perfect that it can't be improved. We must always strive to try new things. Okay, finally, I'll talk about the IOL implantation technique that I use routinely and that arouses much interest in the channel's videos, the IOL hydroimplantation. What is the IOL hydroimplantation? It is an IOL implantation technique performed only under irrigation, without placement of viscoelastic in the anterior chamber. This technique uses a high-flow irrigation instrument to maintain the anterior chamber through the side port, generally of 21 gauge and with an irrigation pressure of about 110 centimeters of water. The IOL is implanted with a syringe-style injector, which means without a thread, although it is possible with the threaded one with the help of an assistant. The irrigation instrument is used to position the IOL and protect the endothelium, ideally with no OVD in the cartridge. This is possible depending on the IOL model and cartridge. Let's watch the technique. Immediately after cortex management, the high-flow irrigating instrument goes through the side port to maintain the anterior chamber pressurized, while the plunger injector delivers the IOL into the eye. The leading haptics are already directed inside the capsular bag. The irrigating instrument is positioned over the IOL to protect the corneal endothelium and immediately press it down completely inside the bag. Same thing in this video. Should the trailing haptic get caught by the incision, as in here, it poses no issue, being easily positioned inside the bag as well. IOL positioning or rotation can be easily managed with the high-flow irrigating instrument. A small pupil poses no issues to hydroimplantation, as can be seen in this case. The leading haptics are directed into the capsular bag upon IOL injection, and the irrigating instrument presses the IOL down completely inside the bag. A quick anterior chamber final lavage ensures that no OVD remains. The hydroimplantation technique can be performed even with low irrigating pressure, as seen in this case, with an IOP irrigating pressure of 50 millimeters of mercury, equivalent to around 68 centimeters of water. If OVD is put in the cartridge for lubrication, it can be simply washed out through the main incision. The IOL hydroimplantation provides many advantages. It is easy to learn, and with it, there is no viscoelastic remaining to be aspirated, completely eliminating the OVD evacuation step with a very significant time gain. Complications associated with aspiration under the IOL, a step considered difficult by beginners, are eliminated. By reducing the remaining viscoelastic in the eye to almost zero, there are no postoperative pressure spikes and also potentially reducing the inflammatory reaction to viscoelastic and contaminants. This technique is the one that greatly reduced my surgical time. Of course, the right mindset is important in surgery. Never be satisfied with your abilities. Have the humility to see your limits and be able to improve. I have these and many more different cataract surgery techniques on my 2 YouTube channels. Please take a look. Thank you for your attention.
Dr. Neto, wonderful techniques. If you can unshare your presentation. Dr. Neto.
Yes, I'm. Yeah.
Can you unshare your presentation so that
Yeah, sure.
you'll be screen on, you'll be there on screen.
I apologize. I'm not fine. Yeah.
No.
I think it's minimized.
Yeah. Once again, I'll do it from my
Okay,
side.
you draw. Yeah.
So
Yeah, it was hidden somewhere in my desktop. I wasn't fine. Sorry.
Dr. Neto, mind-blowing presentation. See, we'll just start the discussion as such.
Okay.
So,
Thank you.
the wedge technique, you're basically using the phaco tip as a knife or a dagger. You're just you're not holding it. It's there, just there. Is it just staying at the center, or you're using it as a dagger, pushing it in as the chopper comes towards it? Because you said you're not going to crush it. So when both are going to each other, you're actually crushing it. So the question is, are you going to keep it at the center, just at the center, to stabilize the nucleus and bring that second instrument to your dagger there, your wedge there? And another question, like if it is very soft, it's a grade 1. Grade 1. So is this going to work? So Dr. Sai Kumar has also joined. He's the president of Kerala Society of Ophthalmic Surgeons. He's another real prolific surgeon, and he's a chief organizing secretary for our main All India Ophthalmology Society annual conference, which is going to be held at the Queen of Arabian Sea, Kochi, in the month of May. So Dr. Sai will be joining the panel. So coming back to my query, like, are you going to take it both to each other, or you're going to just keep it to stabilize the nucleus there and bring it?
No, I keep the phaco tip in the center. The tip, in truth, it doesn't act exactly like a knife. The mechanics of the technique uses the principle that by presenting the phaco tip as a wedge, it has a point. So when you bring the chopper against the phaco tip, the pressure is concentrated on the in the phaco tip, on the very tip of the. So it's a very small area. In this way, let's say it initiates the fracture, and the fracture easily propagates. You don't look like you usually, as you can see, as the fracture is starting, it usually progresses up to the chopper's tip without the need of the instruments to get together. Some nuclei are better suited for this technique, like grade 2 or grade 3 are the best ones because they are somewhat brittle. They are not so soft. In softer nuclei, like a grade 1, as you asked, the phaco tip, the tip stays in the center, and the phaco just let's say almost goes until to meet the phaco tip. The phaco tip acts in this nuclei like holding the nucleus in place to allow let's say a more efficient action of the chopper. In some of my videos, you may notice that when I'm completing, when the fracture is being completed, I slightly go with the phaco tip forward and sideways, and this has the reason for that. It's a very subtle movement, but the reason for that is to help the nucleus piece to detach from the equator, so it facilitates me afterward, when I'm, let's say, doing the fake emulsification, not to need, I don't need to go with the chopper behind the nucleus piece and bring it. It's already loose inside the nucleus. And I think a good tip that I would give, it is more efficient to get the nucleus completely divided in advance. Not to, some surgeons prefer to, let's say, divide a piece and then go and emulsify and then crack another piece. I think it's better to completely divide the nucleus first, because as the nucleus pieces are let's say, they keep the...
Dr. Sai, can you mute? Okay.
And
okay,
as the whole nucleus is inside the bag, it helps maintain the nucleus pieces in place. So especially when the surgeon is accustomed to, let's say, manage the nucleus pieces by using vacuum in the traditional phaco shop way. So some surgeons have difficult to, let's say, only using mechanical forces, maintaining the nucleus piece in place. So this is let's say a tip that I recommend.
Yeah.
Any difference in angle tips and straight tips, Neto?
Oh yes, for sure. Kelman tips, as the one I use, Alcon machines, are easier to use, to be used with this technique, but a straight tip can be used. But let's say a 30-degree straight tip, you can perform it, but you must use let's say, you must be attentive to the angle of the tip when it's sideways, and go with the chopper at the bisector of this angle. This is the most efficient way. So let's say the tip is is like here, and the bevel is like, your chopper doesn't go like that in the traditional as in the traditional mechanical fracturing technique. You go like this because you must follow the bevel. Okay, this is an important thing. And I think that longer choppers are better suited for this. 2.5 millimeters are needed for harder nuclei. 2 millimeters, you can be 2 millimeter bend chopper, you can use in most nucleus. Most surgeons are afraid to use longer chopper, but it's only a question of getting used to. So after a while, the surgeon is comfortable using a big chopper, getting it, let's say, in the equator of the bag without seeing if the pupil is small. This gets, let's say, I usually say it's like driving a car. After a while, you don't notice that you're changing gear and you're managing. You just drive, and let's say, you're not.
It happens at the spinal level.
Yes.
It happens at the spinal level. Not, you don't think about it.
May look like, especially for surgeons who are accustomed to make vertical chopper, the idea of getting something behind at the equator is somewhat scary. But these are very safe instruments. It's it has no issue at all. So it's after the surgeon begins to use the technique, it becomes second nature.
So what do you use for making the side port? And you talked about that high flow instrument for irrigation. Yeah. You said 21 larger than 21G. See, what do you actually use it for? Because when we do the hydroimplantation, we use that bimanual irrigation aspiration. Use the irrigation for that. So the irrigation in the instrument that you use, do you feel that it is larger bore and gives more fluid inside?
Yes. When I started doing this technique some 15 years ago, I used the regular irrigating handpiece of the bimanual IA kit. But it's usually it's a 23 gauge instrument with two side irrigating bores. And it's I think it's insufficient for a good anterior chamber pressure. In fact, I think it is insufficient also for bimanual IA. This is one of the biggest problems when doing bimanual. The irrigating fluids, I think it's insufficient. You must, let's say, it should be larger. And then I started using the irrigating cannula that came with the vitreous probe that came with alcohol machines, which is a 21 gauge cannula. It has the green hub, which identifies it as a 21 gauge, and it's a good one. And then I made some cannulas with this gauge, and I made them different. I prefer, I don't know if I have an easy picture to show, but the cannula, the instrument has a long bevel, a very long bevel, which facilitates insertion, and the bevel is faced down. So it directs the flow downwards. It's I think it is of no advantage to have an instrument that it has a dead end and has two irrigating holes. Some bimanual IA kits that you may find for some manufacturers have let's say a front-facing irrigation handpiece and with very thin wall. Mine don't have thin wall. It's very difficult to find that to manufacture, but it can be easily done by some instrument manufacturer with a 21 regular hypodermic needle. It's just a question of blunting the needles and then making the appropriate curve and etc. So this is one of the things. I open my side port is about 1.2 millimeters to allow easy insertion, and this is important. It's an important detail because the probe, the irrigation instrument must go over the IOL. It must not stay only, let's say, near the side port, because then you're not able to, let's say, maneuver the IOL. It's important that it's across the IOL, over it, and when the IOL gets in the eye, you can push it down for safety reasons, because if not, the IOL may tumble and may get out of place and may hit the endothelium. So the side port must be sufficiently larger to allow you to maneuver the instrument easily. So I don't think this is of any issue, because for the Indian surgeons, because most Indian surgeons are used to make slightly larger side ports, because they like you like to use the Sinski, the Cinco the single cannula. So yeah, so you're used to use it in the SICS. So as I see many videos from Indian surgeons, I noticed that the side ports they made are larger than what let's say non-SICS used surgeons perform. In let's say surgeons that do not perform SICS usually make very small side ports to avoid incision leak, because they only need to pass the chopper right now. And to perform
as long as you don't manipulate that side port, it's not going to leak. Like 1.2 is easily closable. That's absolutely not going to leak at all.
Yes, and to perform the spin, let's say take the opportunity to comment on that, you need to have a sufficient large side port, because if not, you won't be able to get the spin, the chopper in let's say more extreme locations. So you must be able to maneuver it freely, and it's very important to notice to be attentive to, let's say, make the fulcrum movement outside to make the perfect circle inside. This is I think this is the most difficult thing that surgeons have to master when doing the spin.
Quick question about chopping. What do you do in situations where the posterior plate is very thick and there is a leathery brunescent kind of cataract? What is your
I have many hard nucleus techniques that I employ. The wedge chopping is not able to cope with that easily. I don't think it's efficient. I usually perform the Mohanta submarine chopping in these cases. And let's say I perform the submarine tunnel inside the nucleus, and after the first crack, I do like a regular phaco chop technique, getting the nucleus with vacuum and using it. Because if you try to get a harder nucleus piece and do a mechanical fracturing, it might twist, and it's more difficult. And you're able to use some of the concepts of the wedge when doing harder nuclei, because as you start the fracture, you can let go of the vacuum. You don't need it anymore, and finish the fracture mechanically. So it has a beneficial effect, because in this nuclei, when you're doing, let's say, when you're managing a harder nuclei, you must use high vacuum to get hold of it, and then when you lose, when you get occlusion break, you have surge. So by combining a little mechanical fracturing at the end, letting go of the vacuum, you avoid this occlusion break and avoid surge. So it even improves your harder nuclear technique, but you must use vacuum or traditional nucleus fracturing technique with harder nuclei.
What is your preferred chopper for harder nuclei?
It's the same. It's later. Dr. Atul Badiani has a raised hand. And then after I will, yes. And so
yes,
I use this chopper for for all surgeries. It's a 2.5 millimeter chopper. It has a very thin neck. This is a very important detail. So it doesn't need to have a cutting edge like some choppers do. And it has the ball, a small ball at the end. I'm developing a thinner chopper right now. I have some prototypes that I'm using that are better suited for, let's say, a Nigra cataract, and they are able to slice it in a better, let's say, more efficiently, and also in harder, when you have a very hard nucleus, you almost have no cortex and let's say an epinucleus. You have the nucleus and the capsule. And so if your chopper has a slightly larger ball end, it's not easy to get it under. So this new chopper for harder nuclei has a smaller ball tip. It's safe on the capsule, and it's more efficient. Maybe it's going to be used in all cataracts, but I like the larger area chopper because on very soft nuclei, the large area provides support when you're let's say turning the nucleus around and moving it. So the chopper is the same. I use only this model chopper for all my surgeries. I have others that I use, of course, but this is the routine one.
Dr. Neto, before going to Dr. Atul, I'll just introduce Dr. Atul. Dr. Atul holds a Limca record for the most number of phaco surgeries in a day in India. That's 257. So, like, see, what is your highest number in a day, and what is your routine numbers in
Oh yeah.
in a day.
So yes, I was just talking to Sunil. I think I'm really embarrassed about talking about numbers, and this is usually not the way that
Yeah, I understand.
something that I like to convey how
But I
many
just want
surgeries
to.
I have performed and then
No,
how
no,
fast.
no, sir. Like I understand.
Yes, I
I
know.
just want to bring that quality.
Yeah.
That see, I'm not bothered about numbers.
Yeah.
I'm bothered about the quality that is maintained when you're doing the numbers. So when
Yeah.
you say this is the number that I'm doing and I'm maintaining the quality, I want to bring bring the discussion as to how you
Yeah.
maintain the quality, how the sterility, the
Yeah.
results, the post-op refraction. So it's not boasting about the numbers. I'm not bothered about
Yeah.
boasting about the numbers. But when the number comes, the quality along with that comes. So we are all bothered about. See, we do 10 cases in a day, 20 cases in a day, 200 cases in a day. What we are
Yeah.
bothered about is the result of each case. So just coming to the discussion, so that people will know. Okay, you're doing this much and you're maintaining quality. How do you maintain it? So what is the number that you're doing?
Yes, okay. The highest number that I performed, it was not, let's say, on purpose, because I must explain how we work. It was 234. I made this number 2 days. It was, let's say, 5 years ago, common for me to do 200 surgeries a day. All this changed after COVID and after I started using the Ingenuity system. Before that, the mean number was 175 surgeries per day with 2 surgical tables, okay? And since COVID, I'm working with 1 surgical table, and my mean number is exactly 100 cases per day. And this has a reason. I have changed some things in my surgery, and I must say also, I'm getting old. It's not easy to, let's say, it's one thing to do it one day, but I do this like 20 days straight, every single day. And it's not easy to maintain this high number with quality. So I have made some modifications in my setup to ensure quality, and I let's say, I try to stay at 100. Sometimes I do 120 cases, but I try to stay at that number because I think this is good for me, for my team. We can do more, and sometimes we have to do more because, as let's say, I'm going to explain why I have not much control about the number. When we do surgeries, I do in some cities, in sometimes remote places in Brazil, and these are let's say somewhat bigger cities that receive patients from a large area, and we have a schedule that some cities are going to send some patients, and let's say someday we have about 150 patients scheduled to come to be evaluated and to be operated, and let's say some 3 cities are scheduled to send patients. But it's not uncommon for some city to, let's say, do a mishap and send patients on the wrong day. So instead of sometimes receiving 150 patients to be evaluated, we receive more than 200. And these patients came from 200, 300, or 400 kilometers afar. We can't send them back. So I have to operate them, because this is something that, of course, many of you do high volume surgeries, and is usually with this it's difficult for the patients to get access to the surgery. So we do everything on the same day. The patient is evaluated, gets all the examination and operated, and go back, and then go back on the next day to be evaluated, and afterwards, usually after 30 days. So it's not I can't send the patients back because they came on the wrong day. That's why I ended up doing some 234 surgeries someday.
There's
But
one more query here. Like in our country, our ophthalmic association, National Ophthalmic Association, is All India Ophthalmological Society, and the National NPCB, National Program for Control of Blindness, they had put a cap on the number of surgeries a surgeon can do in a day. So it was like the NPCB had come out with this thing of 30 or so, but Arvind people and all talked, and now the restriction is to 50 surgeries in a day in two batches of 25 each. One session 25, the other session 25. So the basic idea was like I've talked to people who have done this. I said, see, if I can do 100 in a day or 200 in a day, why are you restricting me from doing that? Because I'll give as much quality as any other person. They're telling me you can't apply it to the general to everyone. So everyone can't do it that way. If you give a permission to do that, it might affect the quality in some area. So is there any restriction like that in your country about the number of surgeries a surgeon can perform in a day? I believe it is not there, right?
No, we haven't. We have since the year 2000, we have a national, Brazilian national program especially designed for high volume cataract surgery funding. It's a special funding program from the Brazilian Health Ministry. We have similar ones for, let's say, breast cancer detection, diabetes, and so on. But the cataract surgery is the largest and the most, the older one. And it works like that. Let's say I'm not a public, let's say I'm not, we have a
public
firm,
health,
a company,
a
company that gets contracted by the Brazilian government to perform surgeries. These contracts are, let's say, they are set up as open bidding, and all the contractors send their bidding. I don't know if I'm using the correct terms, but I hope I'm conveying the idea. And so the bidding winner gets the contract, and it's either federal or state or in a municipal, let's say, level. We have many, and we have nowadays we have, let's say, constant. We have contracts that are automatically renovated because we are performing this for so many years. So it gets let's say we don't have to apply to that every year. But as we do, and like me, there are many surgeons in Brazil that perform that with the same volume. I have many colleagues that do that same volume of surgeries, and it's only possible, I can assure you, it's only possible to do high quality surgery if you do high volume. If you're going to do 20 to 30 surgeries a day in the public health system, you won't be able to achieve quality, because if the economy of scale that allows me to have 2 Ingenuity system, 2 Constellation machines, 3 trucks that takes all the things around, a big, let's say, a big staff of 30 people that accompany me everywhere and provide the accommodation, food, and everything for them. So I must do 100 surgeries per day to allow me to do that. If I'm doing less, I won't be able to use the best equipment, the best disposables that I use, the medications. Everything I use is the best. The IOL is an aspheric one. It's hydrophilic, and I have a reason to use this one. And all of the things is the best that we have in Brazil. So with the exception of viscoelastics, it's not possible for us to use like a high density viscoelastic like Viscoat or Provisc or Helon on every surgery, but I can use in some. But this is what allows us to have a good quality. And we have some conversations in Brazil because let's say I'm explaining. We don't need to do charity work in Brazil because the Brazilian public health system is open to has a universal access for everyone, every Brazilian, and also foreigners that are in Brazil. I regularly operate like people from Venezuela, from Haiti, from Bolivia that come to Brazil, and even if they are illegally here, they can ask for health care, and you get it. So it's of course we have a backlog of surgeries, but mainly concentrated in some regions, and in this way, of course, we provide a very good quality surgery, but we don't implant premium IOLs. We don't, because we must use only one kind of IOL. The patient is not allowed to pay for nothing. So even if they pay, say, I'll pay for the IOL, for special IOL for me, or I'll bring a special IOL for me, I can't operate you then. You must seek a private practice or something else. But as we do many surgeries, of course, and sometimes some colleagues, let's say, we have issues with some colleagues because they don't want the public health system to work because they want the patients in their office. But it's, let's say, they are wrong about the notion that if the patient is not going to be operated by us, he will go to them because they have no means. They are very poor people usually. So this doesn't correlate to the truth, but in some instances, let's say some colleagues try to hamper the Brazilian public health cataract system. And there was a talk about sometimes about limiting the number of surgeries, but let's say, we could easily demonstrate that if this was the case, almost all the providers to the public health system would go out, and we would abandon that because it wouldn't be possible for us if we would only be able to do like 30 or 50 surgeries per day. And as we and contrary to, like, say, all of you know, all of you that perform high volume cataract surgery, you know it. It's not the surgical time that is the most important thing. It's getting the time, all the rest to be efficient. You have to be have a team. You have to diminish idle time between patients and everything. That's how you'll be able to perform 100 surgeries a day. If you visit me, you'll be very surprised to see that we work at a leisure pace. For me to perform 100 patients, it's like we can do it like 12 to 13 patients per hour. That's our average now. And that
is in one table or two tables?
One table.
Great.
And it goes like, let's say, you don't see any hurry because everything works perfectly. And these and many other things are the responsible for, like, we be able to do with such high quality. And I'm proud to say that our last endophthalmitis case was in 2017. About 90,000 surgeries ago. And I have like 70 or 80 surgical kits. They go, we make, let's say, the rapid formal cycle. We only use like the flash sterilization for some instruments, like special instruments that we have few, and sometimes like micro scissors and something like that, that we know that there will be a case coming soon. Then I must send it because I don't have 80 micro scissors available. But everything follows the rule here, and as we provide surgery, provide the service for the public health system, we are very, let's say, strictly audited by all the authorities regarding, let's say, following all the guidelines that they ask. Much more than private, let's say, private practice, because they usually don't audit the private practice, but they audit us. So we must show that we do everything by the norm. And this is good because we are, let's say, we are not only proud, but we are safe that everything that we do is being audited. And if, God forbid, something happens, we have their, let's say, how to say, their testimony, we have their approval that we're doing everything right. And it's, let's say, we take everything we do as we were doing in the private sector. I have a private hospital still in Ribeirão Preto. Sometimes I perform surgeries there for colleagues, and I say to them, I do better surgeries in my setup with my public patients than I do here, because I don't have my team here and I don't have my setup, and I have to do things like slowly and stop and go out and wash again. And this takes the mind of the surgeon out of the surgeon. It's very beneficial when you're doing one case after another. You get the focus, you don't lose that. This is something that only surgeons that do that can appreciate. It's a completely different game, and much better for the surgeon and for the patient when you're doing it constantly than stopping, going outside on the corridor, let's say, have a talk, and then 15 minutes later you come back and start all over again. This is not good for surgery. It's better if you do one case after another. You don't lose your position, you don't lose everything, the focus, etc. It's completely different.
Absolutely understandable, Dr. Neto, and we are really impressed by the program that you have in Brazil, and the funding is mind blowing. You have 2 engineers in a public sector system. It's absolutely mind blowing. And see, like during this presentation, or we can have one. See, what I basically wanted to bring out was to see the workflow that you have in your place. See, that is something that we can see. Surgeries, okay, like the modification here and there, that is fine. That is great. That's great. But the system, your workflow that you follow, if we can actually learn from it, that would give us a lot of input as to where we have to improve. See, like as I said, I got scared when these 6 years. So I'm restricting myself to 50 surgeries in a day, but I don't really agree to that. That's the number that I restrict myself to in a day. But even here, if we can understand the process that happens in a place where regularly 100+ surgeries are done, and that too so smoothly, single table, 13 cases in a day. So, do you have a presentation as such which can actually show the workflow that you have, or will have?
I can show some things. That one of them is I have some external recording that I can show, and this I would like to show. It's only 3 minutes video. It's I think it's it will show how to be efficient in surgical time. This is it will be good not only for those who perform high volume surgery, it's good for the regular, let's say,
Yes.
every surgeon. But I'd really I'd like
Dr.
to
Atul.
answer
Atul,
Dr.
let Atul,
Atul.
yeah, he's been waiting.
Yes.
Please come in.
Yes, thank you, Kerala Society of Ophthalmic Surgeons. Thank you, Dr. Shreni, for adding me as a participant. I would like to share my views in a nutshell. In short, I will give a brief introduction. I am doing high volume surgery for last 15 years, and I have done in my career almost 175,000 surgeries so far. Now, as Dr. Shreni says, we now follow the protocols set by the National Program for Control of Blindness. I was doing more than 100 or 200 surgeries previously, not at present. At present, we follow the guidelines set by the NPCB. But I will share few tips, just as Dr. Neto rightly said. This swab and spin technique is very good, but I prefer a different technique. I do very minimal rotation of the nucleus. I just rotate only 3 to clock hours just to ensure that the nucleus is free. Then I remove the nucleus and remove the cortex, which is opposite the incision. And only the sub-incisional area is a little bit difficult. In that case, I use the chopper. I use more Rosen type of blunt chopper, and I use that chopper to loosen the cortex from the sub-incisional area. And then I remove it with the use of phaco probe only. And in most of the cases, I don't require any IA probe or bimanual probe. I do only one side part, that is for the chopper. I also do hydroimplantation, but only in case of hydrophilic lenses, not in hydrophobic lenses. And in the high volume surgeries, we are doing free surgeries. I'm working in a charitable hospital. So we use hydrophilic lenses free of cost to all the patients, which comes under in the charitable hospital. And for that, we are getting the funds from the government. And your irrigation cannula while during hydroimplantation of the IOL, that is a very good instrument, and that is a multi-purpose instrument, as you said. But some of our surgeons are using an AC maintainer also, which the works like in the same principle. That is, they are inserting the AC maintainer at the beginning of the surgery. They don't use visco even during phaco, mainly in the softer cataracts. So that maintains the entry chamber and protects the endothelium a little bit, maybe a little bit less than it is done by the viscoelastics. But in the softer cataracts, where very less energy is required, it hardly matters. And most of the time, we use only 3 to 4 seconds of the phaco. Phaco power is used only for 3 to 4 seconds. So usually next day cornea is very clear, and in this way we are doing almost I'm doing a surgery in a softer category. My average surgery time is approximately 2 minutes, and we are also using 2 tables simultaneously. So I do usually 20 to 25 cases in 1 hour with the 2 operating tables, 2 assistant, 2 phaco, 2 microscope. Everything is 2, only surgeon is single. But that was, we were doing a few years back, and now we are following the guideline given by NPCB, and now we are restricting our number of surgeries. But even previously, we were getting good results. Very less percentage of endophthalmitis, very less complications like PCR. Just I want to share that the speed comes only when you are a good surgeon, only when you are doing very smoothly without complication. Then only you can get the more speed, and you can do more surgeries with the full concentration and full your attention. When there is a single complication, your speed comes down drastically. So we have to keep in mind that there should not be any complication, even not a descemet detachment or PCR. And then only you can get the higher speed gradually. So this is the main secret, and only the practice makes man perfect. That is the basic principle. And thank you again, everyone, for viewing this webinar and viewing my view.
Dr. Atul, thanks a lot for joining in, and thanks a lot for the tip. Like you, as you said, you have one complication that spoils the coming surgeries, and also so it's like I keep telling. The complications come in the early stages of the career when you're ignorant. Later on, it's because of complacence. So don't be complacent. It's let's think that it's not the numbers. It's the patient's eye, and so if we treat it that way, everything is going to go fine. Before we move back to Dr. Neto on his work.
1 minute, sir. 1 minute, please. 1 minute. One thing, we should enjoy the surgery. That's the secret. There, it should not be a burden. It should not be an overload to our mind or our body. We should operate only when we are enjoying the surgery. Moment we are feeling tired, we should stop the surgery. Then at that moment, you are losing the concentration and you may end up with some complications. But just with the grace of God, I can say I am doing 200 surgery when I was doing. Even still, today I am able to do. When I am doing 200 surgeries, my last surgery is at the same speed and same concentration as my first surgery. I never feel tired till I am doing the surgery. When I finish the surgery, then I may take some rest after going to home. But during surgery in the OT, I feel that I am very happy. I am enjoying the surgery. That is, I have patience.
Absolutely,
So
Dr. Atul. See, all of us who are doing surgeries in number, that is during surgery only we relax. So that is when you relax. So Minu, any comments before we move on to Dr. Neto on his workflow presentation? Minu?
Yeah. Thank you very much, and fascinating to see these techniques and the way you deal with large number of patients. I'm eagerly waiting to see how is the workflow like to do on one room, one table, and do 12 to 13 cases on in an hour. And these techniques are all quite good. I'll start rotating more now. I also rotate very less, but I spend some time aspirating my cortex, but then I should also start rotating. And my chopper is also similar without this ball tip. It's quite 1.52 millimeters long. And I like going to the equator. I was just saying thing in 2007, I had presented in ASCR as this push-pull. I used to call it push-pull phaco pre-chop. Just almost similar to what you do in this wedge chopping. And fascinating to see your procedure. Let's watch the workflow rather than wasting time on discussing on this. That will be very fascinating to see.
Yes. Thank you, Dr. Atul, for the comments, and you are right on everything. It's unfortunately some people that, let's say, get to like the restrictions they pose. These are done by people which do not have the experience of doing high volume cataract surgery, don't know how it works and why it works. And so this is a very bad thing, because India has a much bigger problem of cataract than Brazil does. We have in Brazil around 20, I think now 22,000 ophthalmologists. In India, I think you have 27,000, but our population is 7 times lower than yours, so you need much more. And if there is a country in the world that needs to cataract surgery to be performed, it's India. So it's I don't understand this, because this kind of thing, limiting the number of surgeons, does not ensure quality. Quality comes from the surgeon. It doesn't have anything to do with the number. Of course, you have each surgeon will do the number that he's able to. Many of the techniques Dr. Atul mentioned, I have tried and sometimes performed, but I have, as like say, doing hydroless surgery, viscoless surgery in every patient, it's not possible. And so I try to stay or to make a technique that I would use in most cases without having to choose and change instruments. So that's why I choose. But these techniques that he mentioned are excellent, and the mechanical cortex liberation it's a very effective, very efficient technique. Many things that I do not show in the channel because I don't think I'm very wary to convey the wrong impression that some things are easy. And so, and most of my audience in the channels is young people. And when they come to visit me, they want, the first thing that they want to learn is how to aspirate cortex with the phaco tip. And I do not think that this is for beginning surgeons. This is very difficult. It requires a lot of experience. It requires a reason. It's not, let's say, you do not need to perform this if you do 10 surgeries in the morning. You have no need to do that. It's better for you to get the IA, regular IA, and do it. We do that because it saves time, is efficient, and as we do it 100 times a day, we are able to do it safely. If you do not do this, you won't be able to do it safely because it's very difficult. So some things I restrain to show in the channel, not to convey the wrong impression. That's why I do not talk about numbers in the channel and everything else. So I would like to share some slides just to give an idea of what we do. I know we do not have much time to discuss or to let's say, to talk about many things, but can I share my screen? Yeah?
Please share.
Okay. Okay, is it playing?
Yeah, visible.
Okay, so what I think if I were to say the most important thing you must have or do or something like that to perform high volume surgery is to have an efficient team. You must lead by example. You must convey to your team task given is equal to a task done. It's like in the army. You must not get have your head you preoccupied with things outside the surgery. I was able to build a very efficient team by making them rotating positions. That is, everyone, I have usually about 7 or 8 people inside my operating room, two doing instrumentation, 1 at the phaco machine, 1 or 2 at the surgical table, 2 positioning the patients, and 2 people in the sterilization center. All of them rotate what they do each city we do. Let's say I usually stay 4 to 5 days in a city. In some day we have let's say all of them have position. The next city they rotate, like in a volleyball team when they do rotations on the position. This ensures many things. It gets the let's say the staff gets to better know each other. They know how to do every task. They know how to anticipate what the other colleague will need at that time. No one has let's say a better position or let's say a better post than the other. All of them rotate, so they do the same work over the time. This is very beneficial in many ways. It's important to build team pride, confidence, and companionship because we work long hours. It's a very difficult task which requires constant attention to the patient, and this is very difficult. The most difficult thing I have in my practice is maintaining my team happy and maintaining them working in good conditions. This is most important, because without my team, I am nothing. It's very important to convey that. Many colleagues say, "Oh, Neto, how do you do that?" I say, because of my team, and I have a big team, and they are happy, they are very well paid, and they say, "Oh, I can't do that." I say, then you can't do high volume surgery with quality like that. And my team is my family. I stay with them more than I stay with my family. So we are a big family. It's a very happy environment to work, and this is most important if you are doing, let's say, high volume surgery. How to improve your technique? This is most important. This is some items that Ivo Ferreira from Mexico talks in his university in Mexico. He has a wonderful teaching facility there, and there are three main things that the surgeon must pay attention to improve the technique. One is consistent environment. You must control everything that you use, from the instruments, from all the medications you use. Everything must be under your control, and this must be consistent so that you can evaluate your technique better, knowing that everything else is the same every time. You must do deliberate practice. What is that? When you're performing a surgical step on some technique, be it something that you do have been doing for a long time, or you're starting to do, you must do it deliberately. That means paying attention to quality and make it perfect so that you can go on. And you must ensure immediate result evaluation. You must ensure that what you're doing is getting what you want. So these are three things that it's important for you to improve your technique, be it on high volume surgery or not. So this is one big important thing. The surgeon must perform each surgical step perfectly. This seems obvious, but it is not let's say, in the usual mindset of many surgeons. Many do the step just by doing. Phaco is a step-dependent surgery. Of course, you must do some step perfectly so that the other one doesn't get hampered by your imperfect technique. This is very important. You must have control when doing performing your step. So avoid performing the surgical step without being in control or just bureaucratically. This is especially important in complicated cases or during surgical complications. It's common for the surgeon to, facing a complication, he or she wants to hurry, wants to get over it fast, and this is the opposite that you must do. You must stop, think, and do one thing at a time, controllably and perfectly, so that you end this difficult step perfectly and with the result you want. This is most important to have in your mind. So the effort in perfect execution promotes improvement. I do not agree with the saying that practice makes perfect. It doesn't. Practice makes permanent, not perfect. If you do it perfectly, it will be perfect. If you don't practice perfectly, you will never achieve perfection in what you do. You will just, let's say, make permanent the lousy technique that you do. You don't learn to do things perfectly by doing many times. You must think in doing perfectly. One step at a time, always. And the perfectly executed surgical step saves time. You do not gain time in surgery doing it in a hurry. You gain time doing it perfectly maneuvering, let's say, doing everything in the most efficient way. That's the way you make it safer, you make it better, and you make it perfect. I would like to show a video of the operating room. I think this is important to show how we do a surgery in 2 or 3 minutes without hurrying. You eliminate idle time. So in here, you have an external view. In this, I'm doing the microscope. You see, I'm looking through the microscope and I will stay there until the end of the surgery. My assistant has everything in his hand. I know what's coming. I don't have to look. He is maintaining the table, organized in the order the instrument will be used. When I lift my hand, I have instantly the instrument in my hand. So there is no wasted time during the surgery. This is extremely beneficial for the surgeon because I don't lose focus. I'm looking at the eye and nothing comes in my mind. I know that I'll have the instrument in my hand when I need it. You can see on the other side the phaco machine. I have an assistant there that gives the phaco handpiece, and while I'm managing the nucleus, the assistant, the instrumentation technician is preparing the IOL, and everything comes at the right time with absolutely no wasted time. This is how we achieve a short surgical time without hurrying. I'm not hurrying. I'm doing this the surgical steps at my time, always being attentive to do it perfectly, and it's the best way for the patient also, because of course a shorter surgical time is good for the patient's eye, and that is why we achieve short surgical time, not hurrying, but doing it perfectly and having someone to assist you at the right time. So you can see that everything stays in place. We have a surgical tray cover in the over the table, and when the surgery finishes, all the instruments are there, and the person that receives it at the sterilization center for processing know which instruments, how many should be there, and instantly notice if something is missing. This is very beneficial for, let's say, all the workflow in the sterilization center. And so, as you see, the surgery finishes. I get out of the microscope, and all my focus was in the surgery. This is very convenient for me because I don't have to pay attention to anything else. I know the IOL, the corrected IOL will be there, and everything else. I don't know what's coming. There is another video, but I don't think this is.
Do you have another video on?
I don't know. We have time. I can show some. Wait. Sorry.
How you change patient? How do you save time in between patient?
Yeah.
Oh yeah.
The cleaning process. And one more question I have is, how many set of instruments do you have? Like you do 200 surgeries in a day. So how many set of instruments do you have? And in case you don't have those 200 sets, how do you sterilize in between?
Yes, okay. I have around 70, I don't know the exact count, but between 70 and 80 complete instrument sets. That's what I use. But in our routine, I usually use around 45. That's the number that gets, let's say, in the process. We have some in backup, but one thing that I noticed over the time is, you must have, let's say, you get your autoclave processing time. Let's say if it takes an hour to do the complete processing, the complete sterilization cycle of your material, we do the rapid cycle with drying time. Okay, so we do the strict, let's say, formal protocol for processing instruments. In some instruments we use flash cycle, but it's not our routine. We do that, the rapid cycle with all the rasterability. Yes, everything is identified for each patient, so we know if something happens, which batch was, everything else. It's everything is recorded like it's required. But if your, let's say, your instrument processing time, sterilization time in the autoclave is 1 hour, okay, then you see how many surgeries do you perform in 1 hour. Let's say it's 10, okay? You will need triple times that in number of surgical sets to, let's say, adequately go through your day. So if your autoclave takes 1 hour to do the cycle door to door, I mean, putting them and then open it door to door, you perform 10 surgeries in that time, you will need 30 instrument sets to do it, because you have some inside the autoclave, of course, some inside in the room that you're using, and some being processed, washed, and then rapid and everything. That's let's say,
I
works
understand.
for me.
Yeah, it works.
It's a rough number, okay, but this can be translated to most of surgeons. It's in my experience, quality instrumentation is essential. Of course, things are very expensive, but over time they save money because they last. I have surgical instruments for my residency, and not a few, a lot. They are 34 years old, and I use them almost in a daily basis, so that I'm not able to do that with cheaper instruments. Sometimes I buy cheaper instruments to see how they work, and then I have an excellent instrument maker in Brazil that I have known him from 30 years, and when I have special instrument, I ask him to do it. I am setting up an instrument factory, an ophthalmic surgical instrument factory. I have all the equipment, the CNC lathe, everything. I do it. Let's say I'm not yet formally installed, but sometimes I make some instruments for myself, and I develop instruments, and this facilitates me very much because I know how I use them, so I can make them. And hopefully I was ready to get it running, but when COVID came, it completely changed my routine. So I think it will be some 2 or 3 years before I can establish that and begin making surgical instruments in a high volume. So this is, I think this is what I was saying about the instruments. This is very important. You must strive to do your sterilization, everything perfectly, because of course, and you must document that. It's in any setting, this is most important. So I have many. It's not easy to maintain this high volume number of kits and to take care of everything, but my team is extremely well trained, and they are able. I'm able to use sapphire knives and diamond knives without them breaking. And some of my knives are 10 years old, and they are very cost effective in the long term.
Dr. Neto, like what Dr. Minu was asking, Do you have a video on like how you move the patients and all? A patient lies down. Do you have a video on that?
Yes, I must find it. Oh, unfortunately, I didn't. I would need to search
No,
here.
that's okay.
Yes,
but
why
I
don't
can
you
explain.
on one.
Yes, I
Why
can
don't you-
explain.
why don't you just show what you were
two
planning
rooms?
to show? You had
Okay.
something in mind, right? You
Yes.
had something in mind. Why don't you show that?
Okay. I will explain how I do it now that I'm using only one table. Yeah. Before I used 2 tables in a novice configuration, so I would just move like that. It was only one phaco machine and a microscope in the middle. Now with the Ingenuity system, this is not practical because the Ingenuity is big. It's not possible to work a way to have 2 tables, and I don't like it because it required me to change my chair and everything else. And at the time, I couldn't use. I was only able to use the microscope foot switch on one side because it wasn't practical to change it, and the phaco machine foot switch would stay in the middle. So when I was operating the patient on the right, I would use the left foot to control the phaco machine, and when I was operating on the left side, I used the right foot to operate the phaco machine. And this is not difficult to get accustomed to, but I would have the microscope control only on one side, and it was very annoying for me because I would have to move the microscope with my hand. I don't have 2 pedals or I would have to change the pedal to the other side. And besides that, I would have to move, and this put much strain in me because moving the chair, adjusting the microscope, it was horrible. Then I got the Ingenuity. All this was like a difference from water to wine, as we say here. I don't know if you have a saying like that in India, but it was the difference between night and day. In the Ingenuity system, I sit like relaxed. I can move my position because I operate in a heads-up position, and I'm very comfortable, but it's only possible with one table. So with one table, I have a patient that's being operated, and we have a chair. The patient the next patient is already in the room. It's sitting facing the other way because it's not many patients get let's say not frightened, but they worry if they see the surgeon. So the surgery being performed. So with the other patients facing the wall, and it's my assistant already does the preparation, the cleaning of the eye. And when the surgery finishes, one assistant takes the patient out and they change, and he changed patient with the other one, which took the next patient in. So this takes about 40 seconds when I'm changing patients. It's very fast because the other patient lies down. I put the surgical drape and the speculum and start surgery. And this is our usual turnover. I don't know if I can say the exchanging patient time around 40 seconds to 1 minute, and then it goes. In many places that I do surgery, I do simultaneous bilateral surgery. I really wouldn't like to go into that because this is very controversial. I don't understand why. It's been my experience more than I have performed. I'm around 280,000 surgeries, almost 3 lakh surgeries, but now much more than half of that were simultaneous bilateral surgery. So I have a huge experience with it. It works. It's not putting the patient in danger, but I really wouldn't like to discuss that because it's a hot topic, and people which do not have experience with that let's say, are against that, think that it's not, but this is the way of the future. But so When it's simultaneous bilateral, there is almost no wasted time between one eye and the other. Of course, you change everything. It's like as if it was another patient. That's how we do. That's how it's been done. So that's how we do this flow of the patient. We have patients that are being prepared outside the room, and my most experienced assistant, when my wife is with me, she does that, is choosing the next patient based on dilation, the effect of oral sedation, or the convenient time to put, let's say, a complicated case or not. If I have to, let's say, we have too many patients waiting and we are behind schedule, we do, let's say, the easiest patients so that we can process a bigger number of patients and let the, let's say, free space and let's say free the most number of patients earlier. So there are a lot of things that let's say particularities when doing high volume cataract surgery. But this that I said, that I have a very experienced assistant choosing and taking care of pupil dilation. If there was only one advice that I would give to a beginner surgeon, it would be prepare your patient well, because this is the most common error I see. I am, when I'm going to, I perform live surgeries in meetings elsewhere in other countries, and if I could choose something, some wish that would be granted would be, please send me the patients well dilated, because that's the most problem I have. Yeah, and I understand it's difficult to adjust the time the patient gets the medication, gets that drop, and at the time that the surgeon will be broadcasted. So this is a main issue that I notice, and for many surgeons, I see that when I see videos, I see this guy didn't prepare the eye accordingly, because you can notice when the pupil could be more dilated. So this would be an advice, and my assistants know that if I notice that the patient was not well prepared, he will get up and wait more and get more medication if necessary, and they will be scolded. So they avoid that and say, Dr. Neto, this one is the best that we could get the pupil dilated. So they put in the table. And this really makes your surgery safer. Small pupil is a very a big hazard for the patient, even in a very experienced head. It's something that can be avoided. So this is something that we take extremely care to prepare the patient, so that we usually know how long it will be like that. If we are doing 13 patients an hour, people who are doing medications know that it is of no use to prepare 50 patients right now, because the dilation time will pass. So they must, let's say, know on how to prepare the next patients, so that when they get into the operating room, they will be at the maximum dilation time. This is something very difficult to achieve. Only with an experienced team you can get this kind. So there are many things in preparation in this kind of thing, but I really couldn't give let's say, a closed recipe of how we do things, because even us, we do things differently according to the place that I'm operating. We have 3 clinics that are ours, and we do surgeries in the 3 clinics in 3 states that are like our main clinic, and there we control everything. And in some places, it's not in a place that ours. It's in an external hospital. We take everything there, but it's in another hospital. And depending on the hospital room distribution, let's say the distance between where the patients will be examined and doing let's say the biometry and everything else, everything changed. But in summary, most of the patients we operate outside our clinics. When they are operating in our clinics, they have the examination, like the indication of surgery, biometry, and many things done previously when they make the first consultation, and then they come back from surgery, like most clinics, in most setups work. But when we're doing in faraway locations, we receive the patient for the first time. He comes sometimes with a diagnostic of cataract, sometimes don't, sometimes only with provision. They don't have an ophthalmologist to examine in this city that is far. So he gets the patient is evaluated, and if indicated, he goes to all the necessary examinations and biometry, and then is prepared for surgery and is operated, and then it gets the post-operative orientation with his accompanying people, and then returns on the other day. This is our routine. And this, just to give you an idea, in regular places where patients are operated in the public service in Brazil, like in some hospital where they perform surgeries in a routine way, usually the patient needs to go there 5 times before getting surgery. This is a very, very sad thing, because this has cost for the patient. He sometimes almost always needs someone to come with him or her, a son or someone to take him, and this is very difficult. He comes and make it the schedule a consultation, and then come to the consultation, and then the guy asks for the exam, the eye exam that he will perform. It's usually not at the same time, so it's something very laborious. And so the way we do, the patient comes and is operated on the same day, with exceptions, of course. If the patient has some other issue or some health issue, he will get a clinical evaluation. But most patients are able to be operated in the same day. And so this is very efficient, especially not only for the patient, because most patients, when they come from faraway locations, it's the local administration that sends them, that arrange the transportation, people who will accompany, and everything else. So it has a cost for this city to send patients, and it's important that they have this cost down, because if you will require them to be constantly coming back from 500 kilometers, this is very difficult. So this is very important to happen all in the same day. This is something that it's in this kind of situation, high volume surgery in the public health system, or like in your charity camps. I think that's yeah. This is an important thing. You must be efficient. There's no reason for the patient to keep coming back. You can see, you can work out. So we have an inventory of about 5,000 IOLs ready. We can't, let's say, order an IOL, especially for each patient. We must have the whole grid, and a lot of it. Because if we're going to, let's say, perform about 1,500 or 1,800 surgeries in a month, we must have everything ready. It's not possible for us to be waiting for material to come, and because we are far away. So we carry everything with us, and we have this large inventory of IOLs and everything else. So it's it requires a lot of preparation and well, I don't know how to convey that, but it's not
absolutely mind blowing.
It's not a small thing.
Process.
It
Whole
involves
process.
yes, it involves a very it's let's say a large volume of money. Sometimes the government takes 2 to 3 months to pay us, so we have to be prepared to, let's say, through these times. It's not easy. It's not easy, but it works
they
well.
They do finally pay you, right?
No, it's 10 years from now. There are strict laws that states that the paying time, and we can only start some program, start surgeries when the, let's say, I'm going to tell them, the local government or the state government can only start the bidding process when they have already received the money from the Ministry of Health. They already have the funds. So there is no, and this is only available for that. So there is not the excuse, oh, we didn't receive the money. Sometimes you get delays in payment due to, let's say, in election time when there is some changing in the government, the money is there, but they are setting up the health secretaries and everything. So some things get because of bureaucracy. It's not because of bad will of them. We understand that and we are prepared for that. So, but it works well. It works well. And I should say this is known, has been known. There is a WHO work that says for every dollar spent in cataract surgery, you save $3 in healthcare. Because people, in general, because people who don't see gets in accidents, gets sick, and must receive some, I don't know how to say, if you're invalid, you have a pension from the government and everything like that. So it takes time for someone to take care. So it's economical to perform, for the government to pay for cataract surgery. They should see that. And it has a huge, let's say, political, it's revenue for the governments that some city, can I say prefectures? Yeah.
Yeah.
You say some municipal, let's say the mayor, sometimes they have some money from the available. It's not money coming from the health ministry. They get some money that the municipality has and spend that on cataract surgery, because sometimes they have many people that need. Of course, they advertise that. I'm bringing, and the political revenue is huge, because I don't know of any surgery that has that immediately result and is as appreciated as the patient being able to return to see. It's amazing what is achieved, and it's very rewarding for us when sometimes you go to some place for the first time. You have 5-6 years blind people that have been blind for so long, and on the next day you see, when we walk on the city, we see everyone with the dark glasses, because we give everything. We give the medication, we give the glasses to protect, and so the glasses, I don't think this is a big thing, but it reminds the patient that he should not fuss with the eyes. So, and then we walk and we see a lot, and we see the extent of our work. And when sometimes we are in a small, let's say a small grocery store, at the supermarket, buying something, and they recognize it, instantly gets a lot of people. Oh, it was you that operated, yeah. And it's a big thing. It's very rewarding, because you see the result of your work. And that's what drove me out of my private practice, because I didn't like it. Really, it was getting more and more boring patients and highly demanding patients, and I don't know how to convey so that I don't look like, but I didn't like it. And working for these people, which are mainly very poor people that have no condition, they are very grateful, and sometimes they bring us things that they shouldn't, like they have some some food, some something that they grow, and even some animals they want to bring us and say, please don't, because I can't accept anything. I know that you're grateful, but and they want to show their respect and their appreciation for what we have done. And it's kind of unfair, because I, as the surgeon, receive the let's say the praise, but it's the whole team and the government, ultimately the people, of course, but the government that provided that. It's not something that I gave. I just did the operation, but they personalized that in me. So it's very rewarding. But anyway, I think I should pass, let's say, the take-home message. If you want to do high-volume surgery, you must do it right. There are many things that you must pay attention, like we discussed it, and also it will be over a long time. You can't instantly begin to perform 50 surgeries a day. It will be a disaster. No one is able to do that without having previous experience. You must build up experience, build up your team, build up your resources to be able to do it safely. You must have everything that is in need for that. It's not easy, and I have many colleagues that start doing that, and they give up in the middle because they say, oh, Neto, this is too demanding. And to work, let's say, for me, it works because I don't mind being outside my home. My wife can be with me for such a long time. It's very good. It's long hours. I live in hotels, but I love it. I love it. And I can say I live a surgeon's dream, that I'm able only to perform only surgeries the way I want, with everything I want, with the people that I chose. So this is very rewarding.
Do you use
Neto,
intracameral antibiotics?
Neto,
Just one question, Srini.
Neto, I wanted to tell you something.
Intracameral antibiotics,
Yeah.
are you using on a regular basis?
I'm sorry. Can you say again?
Intracameral
Intracameral.
moxifloxacin or something are you using at the end of the
Yes.
surgery? Are you putting intracameral moxifloxacin or any other?
Yes. This is absolutely essential. I think there are two things that changed. They were a paradigm shift in endophthalmitis in cataract surgery. One was moxifloxacin, intracameral moxifloxacin, and the other one is iodine povidone preparation and the eye drop in the eye. This is absolutely essential. I think this is, many colleagues still don't use. There are some issues in some countries about using that. You have no special preparations. You have to use in Brazil. We do not have moxifloxacin especially prepared for intraocular use. We must use the alcohol eye drop. We use it, and there are many ways of using it, but it seems to make no difference if you diluted it or not. So I diluted it, I prefer, but many colleagues don't use it as it is. And
Are
so
all surgeries topical? Are all surgeries done topical?
No.
Topical
no.
anesthesia, no.
Oh no. And I don't know. I can say that thankfully, some wisdom comes with age. And of course, experienced surgeons can do practically any case under topical, but it is not needed. And nowadays, I can say that about 10% of my surgeries I do under peribulbar block. And let's say, as I said, most of them are chosen. These cases are previously chosen by my assistant that is outside, taking care of the patients, taking care of dilation. With experience, he or she immediately knows a patient who will need a block. Many of them is to ensure better cooperation, patients which are younger patients, complicated cases, and there are some that instantly are, let's say, elected to have peribulbar block. White cataracts, intumescent cataracts, posterior polar cataracts, loose zonules, and very hard cataracts. These go, let's say, we usually do not, I do not take a look to say, no, I can't do this, because if you do that, you will be doing many of them under topical, and you will regret, not because it will end up well, because you know that when you're we're doing difficult cases under block, you perform it much better, and it's better for the patient. And I have a let's say a mindset that's, and this is in the mindset of my assistant too, which is, if you think in doing a peribulbar block, do it, and do not think nothing else, because if you're going to think a little more, you will rationalize and say, no, I think I can do it, and then you'll regret it. So a big issue is when the patient is a one-eyed patient. That's, let's say, sometimes even in harder cataracts, I do it without doing a block, because if not, the patient will have so little time on the first day. But usually,
do you do subtenance in sort of
usually not. I'm even if I need to perform a block, let's say I start a surgery and there is a PCR, and then I notice that it's better for me to do a block. I do a block, and I have no issue with that. Yeah, peribulbar, yeah, I prefer. And I am sure that this is because I am not good doing a subtenon block. I think it's at my fault, but I prefer to do a peribulbar block, because I will block the IOL too, so I will have more time to perform surgery. So I prefer. But that's a question of preference. I'm not saying that this is better. This works better for me, and so
it's been wonderful, Dr. Neto. 2.5 hours. We didn't 2 hours 15 minutes. One last query,
okay,
if you allow. See what your opinion about flax.
Oh, I in my private practice, hospital, in my hospital in Ribeirão, we have a femtosecond laser, and while I was doing my private practice, I was able to do flex, and we had two machines. Initially, we had the machine from for Johnson & Johnson. I forgot the name. Well, how can that?
Lensair.
I'm sorry.
Catalyst.
Yes, the catalyst. Yeah.
Catalyst.
And I don't know how can I forget, because I was even a consultant for them and but you know, we get old, we forget. But I loved the catalyst. I loved it. I think it was a very good machine. It was the best femtosecond laser that I had the opportunity to operate on, but it was not economically good for us. So we changed it to the Z8. And it was about that time that I stopped at my private practice, but I have some experience with it. I think it's, let's say, it does perform some tasks. Of course, the capsular axis, you can, it's not possible to be so consistent as the laser is, but I can say, after when I started doing surgery with the catalyst, it really made my manual capsular Rx is better because it was a matter of pride. I said, no, I must do this. Man, I must learn how to do that. And I think it enhanced the importance of have a properly fashioned capsular Rx. That's why what happened. And then, but I don't think it makes economical sense. No. And even many places, many surgeons have it for marketing reasons, and even that doesn't make sense because the patient doesn't know much about it. He or she already perceives the surgery as being done by laser, although it's doing by a phaco machine. It's not laser per se, but it didn't catch, let's say, it didn't work, the femtosecond laser, because I think the companies wanted to make a profit for each surgery, so it killed the opportunity for the surgeons to make it, let's say, make economic, because yes, so the price you pay for each surgery is very steep, and it only makes sense in high-paying patients, and even then it's somewhat of a hassle because you have to move the patient. The Z8, no, you can perform it, but it really takes the much time. It's more discomfort for the patient, definitely, because you must put the interface, and it takes time. So the manual, let's say manual phaco, it's not manual, but I say the regular phaco, it's much smoother for the patient. And so I don't think the way it is, it's not, it won't work. Some colleagues still use it. Didn't make the surgery much easier. It was something that many expected. It didn't, and so the incision is not okay because it has to be too much in let's say anterior. You don't have you can't make it on the limbus, and so sometimes the cornea suffers a little if the patient has some vessels there. You have to make it. So these are issues that only the only, let's say, the best thing of the femtosecond laser is, of course, the Rx's. Even the nucleus division it doesn't make much difference, I don't think. So I don't think it will, the way it is, I don't think it will be. So we don't see many companies, let's say, developing it more. They have their machines. Sometimes they have some upgrade, but it didn't change beyond that. I don't think it will catch. But I like it very much of the concept. And when I was doing with the catalyst, you could let's say monitor real time what was happening. It was very reassuring, and I liked it. If it weren't because of the cost, it was something that I would like to have in regular surgeries. I really like it, but it's not economically feasible. Even for the rich Americans, it doesn't. they have it and they don't use it because it's cost, but they pay the. I talked to many colleagues in the States, said, oh no, I have the machine just to say I have it, and because the guy across the street have one, but I don't. I use it in 5% only. This doesn't make sense. So fortunately our surgery is good, and so we don't need it, but it was a good concept, and I would like to have it if it didn't cost like that.
Yeah, like see, this is something that I wanted to ask in between, like, and you answered it also. See, how many of your 4 lakh plus surgery, or nearly 4 lakh surgery that you have done, know that it is Dr. Neto who has done it, so that you are in their prayers. But I mean, from your comments, many do really know that it is you who have operated on them, because it's not just the thrill that you have with the surgery. It's a, I mean, I always tell, like, it's the prayers of our patients that is bringing the best out of us. So it's nice to know that because you're in a, when you're doing mass surgeries, you're working for the community ophthalmology. It might be just that till somebody has come and operated, but it's nice to know that many people do recognize you as the surgeon who has done the surgeries, and they're keeping you in their prayers, and that's what is keeping you young, and probably you'll stay young for another 30 years to keep on operating on such.
Thank you. Yeah. Well, you know, most of my, let's say, of course, every ophthalmologist in Brazil knows me, but the patients don't. They don't know. In most places that it's me, it's Dr. Neto that is operating. They know that it's someone who's coming. And I think this is for the best. There is one city that I operate on. I just came from there the day before yesterday. It's called Penha. It's on the coastal region. It's 900 kilometers from where I am now. And some people in the health secretary there, of course, know me, and they tell the patients that it's me personally, Dr. Neto Rosatelli, which is operating. So in this city, and thankfully only in this city, comes people, and in the nearby region is a very rich region. There is a city there which is called Camboriú, which has a very high level of economics. And many patients come to be operated on the public hospital there, driving Mercedes and BMWs, and we have very, let's say, affluent people there, and they stay in line and they wait for 4 hours there to be operated. They don't mind that they are not getting premium IOLs. They know that the quality of the surgery, and they say, no, doctor, and this is a matter of pride for me, because they say, doctor, I know that you're the one that operated. My people say about you, my ophthalmologist knows you, and I must say that in here, I did not only got a wonderful surgery, but I was wonderfully treated, as I wasn't in all the let's say, the other places that I do, and I paid for that. And in here, yeah, I know that you care. This is a matter of great pride for us. We don't like that people, let's say, they are right, they have money, but they have the right to be operated on the public health system, and they come because they trust. And let's say in other occasions, when we were doing some programs in other regions of the country, I have the opportunity to operate many people, like governors of state. Together with them, they didn't get anything special. They seated there and they waited, and in between the patients, they got, and I operate them and their father and everything, and many people. This shows the level of trust that people have in our service, even doing this high volume, because they know, they see the governors, for example, were the ones that contracted us. So then they came and say, oh, today, next week I will be operated. So they come and we do surgeries. And this is a matter of great pride for us to see that people trust what we do and are happy to receive because I must tell, it's not easy to do such large volume with quality, let's say, providing attention, adequate attention to everyone, because of course people wait for a long time, because there is the flow. It's let's say, usually the patients stay there for 3 to 4 hours to be during the whole process, but they do it, and it's a very a good environment. It's very rewarding way to work, and I think this is the way when I got into medicine that I wanted to practice, to see the result, to do my best, and to work with the good people. That's because I don't think this is the case in many. I have colleagues that have abandoned medicine when they were 40 years old. This is sad because it's such a difficult career to follow, so much study. For you to abandon that at 40 years old, it's sad, because they say, no, I can't stand it working like that. And it's getting, I think, more and more worse. I don't know if you agree with me, but it's not easy to be a doctor nowadays. People, many patients don't appreciate what we do. We don't need appreciation, but they initially see you because their previous experience sometimes is bad, and so they, let's say, man, that all doctors are like that, and it's unfortunate, but I really like what I do.
Yeah, that's great. Minu, Matthew, Sunil sir, final comments from you, and then see. Minu?
Yeah, we would greatly appreciate your time and the particular details which you have gone into to explain how you maintain quality and speed and the kind of dedication you have to these kind of poor patients and the community work which you do with the greatest possible. And you have your facilities and the best equipment you have. That is one great advantage. And we should thank your government and your people there who are concerned very much regarding the healthcare of their community and their population. And they have people like you who are completely dedicated and so skilled to deliver this kind of high levels of quality surgeries in these kind of relatively remote places in your country. Thank you very much for guiding us through this. And we can also think about spreading the news and spreading the training more people on this and trying to get more efficient. And as you said, the team has to be well maintained, and they are, without the one sentence you said, I am nothing without my team. Yeah. That is what should be percolated among the teams which we all have, and they should take the pride of being our support system so that the best results come out of the team. Thank you very much.
Matthew?
Thank you. It's been a great experience listening to you, Neto. And after many years, I've been actually sitting through a complete 2.5 hours presentation, learning new things, small things, and the innovation that you have and the constant thinking in improving and refining your processes to give better efficiency, better clinical results. It's something that's an inspiration for all of us. And thank you. And like Minu said, I hope to be able to spread the message to the people I'm teaching and training. And I think I know Sunil is visiting you. And one of these years, I will come certainly with Sunil and visit you. It will be my pleasure and privilege.
Oh, it would be, and you are invited to visit me at any time. It would be a pleasure to receive you and exchange experience and show how, because one of the things that I used to say is that one surgeon visits the other, he usually pays attention not on the monitor which is being which you can see the surgery. You learn a lot looking around and learn how things are being done, because this is not usually shown. It's only by visiting someone you learn, oh, so you do like that, you say, I don't know, you aspirate like that and use this syringe, use this cannula, all that. So these are seemingly small things, but they are not, because when you're doing many surgeries, a small thing makes a big difference. So this is something that you only can appreciate like that, visiting someone and learning and seeing, and even, and I love receiving visiting surgeons, because it's a fun environment. I'm able to talk with them while I perform surgery, and I learn a lot, because of course they said, "No, Neto, I do like that. Oh, so let's try, let's do." So it's a very good thing to be able to, let's say, do this kind of exchange. So I would love to receive you, and you're all invited. It's just a get in touch and we will arrange. And I'm very glad that I'm receiving Sunil in May. Hopefully, I'm sure you will have a wonderful time. And I'll put him to do some SICS also and some FACO, so that I can learn too. And so I'm preparing for that.
Dr. Sunil is actually missing our All India conference to visit you, sir.
Yeah.
Yeah. Final comments from you, sir.
Yeah.
Neto, the one thing I wanted to ask you, do you know which is the first country to have a national program on prevention of blindness? Do you know the answer to that?
Yeah, well, I don't.
It was India.
But,
It was India.
oh, yeah.
India was the first country to have a national program. And, what we do is very, very similar to yours. I mean, the camp setup, going around, doing, but definitely we have to learn all these things. We are now catching up. Sometimes we have, faltered. Our charity has not exactly, sometimes our charity has faltered in India. And right now, of course, there, people like Arvind and all have shown the way of high volume surgery, high quality surgery. And this thing about the intracameral antibiotic, the studies has come from Arvind, 2 million cases. And still the USA doesn't approve of the intracameral antibiotic because this FDA is so idiotic. I mean, they want to do an RCT of 80,000 cases. How much is that going to cost? So it's ridiculous. But countries like Brazil and India, we are so similar. We don't. We
Sure.
cut through the bureaucracy.
Yes, I think many experiences that we have in the public health system should be, let's say, studied, and because it has taken so much time. Brazilians started this really comprehensive public health system in 1988. So it's been a long time now, but and it's amazing for me to see, as you mentioned, the United States, the richest country in the world, has so lousy health care in every aspect. I'm not talking about all Medicare, but in many, let's say, it's horrible. It's horrible. I know that, I know. I see this. Let's say, I had many patients that lived in the States, Brazilian, that lived there, and they say they compare, because the American people are used to that. It's horribly expensive. It's horribly inefficient, and I don't get it, because they really need, and it's catching up with them now. It's a major problem. It's a major problem. It's I don't know. I really don't understand how they could. You could see what happened during COVID times. It was a catastrophe.
Well, look at their gun laws, and you can understand them better.
Yeah. So it's but anyway, it's, of course, a public health system is expensive, but it saves money, because otherwise people get sick and you lose money in other ways. It should be implemented. It's a very difficult thing to do, and politicians usually don't want to tackle that. And in many countries, they get the let's say the doctors' resistance to that, and but it's in in a wrong way. I have many times have the experience that when we're starting doing public surgery on city, which otherwise didn't have, the local doctors were against because they thought they were lose patients. And when we started doing surgeries, as the surgeries were very successful, the number of patients
Increased.
were larger because people see not, oh, this guy is doing the surgery good. They see the procedure. They say, oh, cataract surgery is good. And so they look for their doctors. And then they were surprised to see this happened in many cities, that their cataract surgery numbers got up because patients began to search for it, and didn't come exclusively to us, of course. So this is a misconception usually encountered.
And we
Wonderful,
thanks,
Dr.
Srini, for inviting me. Sorry, when you rang me up and said Neto Rosatelli is coming on, I said, of course, I'm there. Thank you very much. And
No.
Thank
don't
you
have to
for
talk about your
having
work. Your work
participated.
is fantastic.
So, like, I've been doing these programs like almost every week for the past 1.5 years, and this is undoubtedly the best session that I've ever had.
Oh, thank you. No, it's due to your participation in our discussion. Definitely not because of myself. No.
Thanks a lot.
Thank you.
Thank
Thank
you.
you.
Thank you. Ankit,